Hear me okay?
Yeah.
Amazing. Right. Welcome to today's case review. Excuse the amount of pre-information that we have here, but we'll go through it. This lady was a gravida 3 para 1. She had a previous miscarriage at 5 weeks, and she had a cesarean section in 2021 at 36 plus 2 due to going into labour and having an undiagnosed breech. This lady had a medical history. She had a BMI of 24. She declined a nuchal screen. Low PAP-A was detected at her 20-week anomaly scan. And she also had a subserous fibroid, which was 4 centimetres at her nuchal scan as well. She had 2 episodes of PV bleeding at 16 and 19 weeks. And then at 23 weeks, she was admitted to Queen Charlotte's for a PV bleed, and they put a cervical cerclage in. I'm not really sure why. I don't believe the cervix was actually open at this point. But I've never worked there. I don't know what their guidelines are, and I don't know whether this is a sort of common practice that they use there. At 31 weeks, she was seen in triage. She was feeling some pressure, but there was no concerns. 32 weeks, she had a normal scan, showed normal fetal growth, Lycor and Dopplers. Placenta was anterior high, and estimated fetal weight was on the 67th centile. First episode of reduced movements at 34 weeks, and then she had her stitch removed. And then again, she went into, started to labour at 36 plus 6. She SHROM, so was admitted, and the plan was made for an augmentation after 24 hours. So she was put on Hope Ward with regular CTG monitoring. So this is the 28th. So she SHROM at 9 p.m. and then she came into the unit. I believe this was her triage CTG here. Yeah, the obstetric review was called. She was admitted, and then the plan was for an induction of labour from 24 hours. And this is your CTG. So as we can see, sort of baseline's around 130. Looks like we've got some cycling happening here as well. So CTG looks slightly more reduced-ish variability for the first sort of 40 minutes. And then as you can see, it picks up within the last sort of 8 minutes. We've got some accelerations and whatnot. And yeah, variability looks good. And there's definitely something going on with her uterus, isn't there? But I'm not sure whether they were palpable or not, because unfortunately there's no record of it. Cool. So this is the 29th now. So she's now officially 37 weeks, so she's term. 2:30 in the morning, she was contracting and she was in a bit of discomfort, and she was requesting an epidural. She was examined and found to be 2 centimeters dilated, and then she was given some dihydrocodeine and paracetamol. Unfortunately, this didn't work effectively for her, and she was requesting more pain relief, so was given some pethidine at 3:40 in the morning. Now, there wasn't a CTG done between 11 o'clock and then 9:40 the following morning. Whilst I fully appreciate the fact that this lady is now term, the fact that she's SHROM under 37 weeks and is a VBAC and reasonably high risk pregnancy, I would have expected the CTGs to have been performed at least sort of 6 hourly, whereas this is roughly now like 10 hours since she last had monitoring. Those observations in your top corner were done, I think, at sort of 7, 8 o'clock in the morning, but yeah, all normal. At around 9:50, she's moved to a left lateral position due to loss of contact on the CTG where we weren't picking the baby up. They have reported that she's got no scar tenderness, which is great. We quite often see that whenever we're reviewing cases with VBACs, that actually scar tenderness and that abdominal palpation is really, really important that we do. Even more so because of that risk of scar rupture, or we really, really, really need to be making sure we're palpating that uterus, making sure that there's good resting tone. Although the risk is really low for scar rupture, it is there, and it is higher with, obviously it's higher with VBACs. So please, 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 another yet again, key message that to come away from this is the fact that we really, really need to be making sure we're documenting any abdominal palpation. Taco doesn't appear to look like it's picking up much, but there's definitely some activity that's in place here. And we can see what possibly is a couple of baroreceptor decelerations, some lovely shoulders either side of those decelerations, showing that the baby is very well compensating to the stresses of labour. However, because she is antenatal, this does classify as an abnormal CTG. She was reviewed on the obstetric ward round at around 10 o'clock in the morning. The plan was made for a 6-hourly CTGs with 4-hourly temperatures. The CTG was discontinued here, but then reattached after a fresh eyes assessment by a second midwife due to the fact that there was decelerations. The doctor's review is not very clear as to when they actually reviewed this woman and whether or not they saw this CTG before making that plan. So if we can possibly just get used to documenting that as well when it comes to on the antenatal ward. I know it's difficult because we've obviously sometimes got a ratio of up to sort of 7 or 8 women, but if we can just add the timings in, that would be fantastic, just so that we can clearly know whether or not they've had an obstetric review and if they've seen the latest CTG, essentially. Any questions or comments on this so far? I'll take that as a no. Perfect. Despite the fact that this is obviously technically an abnormal antenatal CTG because she is 2 centimeters, even though that was about 8 hours ago, this is abnormal. So it does need escalation, just for anybody that needs that sort of clarification. So the CTG is sort of restarted about 5 minutes later, essentially. And then the obstetricians were called, so great escalation here. And this lady was reviewed, and the CTG was reported to be normal by the obstetrician. And the plan was made by the obstetrician that she was to have a category 3 cesarean section tomorrow if she wasn't in labour by the 24-hour mark. So essentially, 24 hours from would be 9 p.m. this evening. And if she wasn't in labour by the following morning, the plan was to do a cat 3 for her, because of the fact as well that she wasn't keen to have a Synto augmentation, just due to the additional sort of risks associated with it. She was well informed about the risks associated. However, I don't think this plan was particularly well explained to the woman, and you'll sort of see why in a minute. So yeah, we have got some more sort of baroreceptor looking decelerations with lovely shoulders. Our baseline does remain stable, and it does look like this baby's cycling. So from a fetal well-being perspective, I think this baby is, showing signs of compensation with whatever is going on with the uterus, but something that I wouldn't necessarily be keen to take off too soon, due to those decelerations that are happening, or maybe even examine her and find out maybe if she has made progress in labour, because we wouldn't normally see decelerations for a happy baby this early on in her labour. Cool. So it is kept on. I think this midwife was very keen to sort of be more reassured by this. And then after the next sort of 50 minutes, the CTG was discontinued and this client wasn't in any pain. So the pethidine had either kicked in, or maybe her contractions had just sort of died down, still in that latent phase of labour. Couple of readjustments due to the loss of contact, and fantastically as well in this case, this midwife has documented maternal pulse at this point, so we definitely know what maternal pulse was during that loss of contact period. We really often see it where the CTG looks like it could be decelerating, whereas it actually is maternal pulse. So the fact that this midwife has manually palpated that pulse and written it clearly here is really good practice. So I'd encourage everybody to do that if you're ever in this situation where you are getting quite a lot of loss of contact. Toco's readjusted. I don't know really what's going on between 12:10 and 12:20 here, but yeah, possible movements and whatnot. But we are seeing some sort of cycling here, and baby's still accelerating, which is really good. Everybody happy to take this off, or would we keep it on for a bit longer?
Perhaps just a little bit longer, just because in between the bits where there is a little, like the variability does seem slightly reduced. I know there is like a bit in the beginning, but towards the end it does seem reduced to me.
Yeah. The thing when it comes to reduced variability is obviously, we want, if we're classifying it completely as reduced variability, it needs to be less than 5 for a period of 40 minutes, right? The thing that is sort of reassuring is the fact that this baby is clearly showing signs of cycling. So it's normal for it to be reduced for a small period of time. If you wanted to keep it on for longer to make sure that this was definitely cycling and the variability then picked up afterwards, and there's absolutely no harm in doing that. But to me, this is a sort of reassuring based off of the last sort of hour and a half we've had of CTG, that this baby is going through that active sleep cycle, as well as that sort of periods of quiescence, which is definitely reassuring. But yeah, absolutely no harm in keeping it on for longer, just to make sure that it does pick back up again. If you do have concerns, absolutely. Also thinking about her risk factors, that overall clinical picture here, she's not quite 24 hours, but she's about 18 hours from here. She's a VBAC as well, so we're going to be keeping a closer eye on her. But maybe, I don't know, despite the fact that the obstetric review said to do CTG 6 hourly, maybe you could do it a little bit closer to the time. It is very much clinician dependent. As long as we're monitoring this baby adequately, that's the most important thing. So if you decide to do it a little bit earlier on, then that's absolutely fine. Our obstetric reviews are, always meant to be used and adhered by. But if you've ever got any additional concerns, then there's absolutely no harm in doing something a little bit closer together, as opposed to doing it further apart like they kind of did overnight. Cool. So CTG was recommenced at around 5:45 p.m. So it was about 4 hours later. This is your CTG now. As you can see, our baseline still remains what it was previously. And again, we've got that fantastic maternal pulse that's been palpated there. Toco's been readjusted too. This lady reported a sharp pain in her abdomen at around 6:10, which lasted about 5 minutes and then completely stopped. Not quite sure where that's come from. It could have been sort of fetal movement related and whatnot, and it doesn't appear to be any sort of scar pain from what's documented on Cerner. But again, just wanted to highlight the importance of asking those kinds of questions. Where the sharp pain is coming from wasn't necessarily documented on our notes. So please just make sure that when women are reporting pain, just making sure that it's the right side pain, their labour pains as opposed to anything else. She's not got any report of any contractions at the moment, but I think she is tightening, and we're now approaching 20 hours SHROM here, so we're getting closer to prom. Happy with this CTG?
Yeah.
Yes, and the likewise clear.
Yeah.
Yeah, I'm happy with this one. The variability has improved.
Yeah.
She said 1D cell. That's I don't know what is going on there.
Yeah, they're very baroreceptor though, so I'm not necessarily concerned with it. Although, I still do think this is very much likely to be sort of some sort of cord compression, isn't it? Or sort of fetal movements that's caused it, despite the fact that it's not really happening alongside a contraction. Although the Toco looks very suspect. Sometimes I wonder how much we rely on those and whether or not they are completely accurate, specifically when they're not picking them up very well. But yeah, so this is continued. So as you can see, we've got some lovely accelerations. We've got a nice stable baseline. We've got probably another baroreceptor deceleration there, but loss of contact, so sort of more difficult to interpret. But yeah, would everybody be happy to take this off?
I wouldn't. I'd let it run a little longer.
Why is that?
Because at the end, we can see I know it could be cycling, but just to confirm it's cycling, if we let it run a little bit longer, and it also shows like, I feel like the baseline is like, I don't know, it's like going and coming from 1840 to 1850.
That's fine. There is absolutely no harm in keeping a CTG on for longer for you to get more reassurance of fetal well-being. As long as you've got a woman or anybody that's comfortable and is happy to stay on the monitor. If she's declining, obviously we're going to respect that. But if we are in a situation where you think, do you know what, I want to keep this CTG on for 10 to 20 more minutes, just so that I can be more reassured by what I'm seeing and be more reassured by the fact that what I'm seeing I'm happy with and is showing me that this baby is coping well, there's no harm in doing that at all. And I would so much rather that women were kept on a CTG for too long than too little, if that makes sense. Perfect.
Yeah, it does. And also the Toku, I would want to readjust it for palpate contractions.
Yeah, I don't know. It always confuses me when we see these sort of zigzaggy, very, very low lines on here. You know, I don't know. I feel like the contractions or the Toku is supposed to pick up. So I don't know. Just to me, it seems like it's a strange looking thing, but obviously it doesn't look like we're getting any contractions. They've zeroed the Toko at about 1850 as well. So I wonder if that was in relation to sort of maternal movement or something, the way we're getting the loss of contact as well, or maybe they've adjusted it, but it's unfortunately not documented. But this has continued for a bit longer, for about 20 more minutes. And as you can see, as you were saying, Dashni, that the variability sort of picked up again. So the conversation is now had with the woman about having a category 3 cesarean section at the following morning. And this woman was quite distressed by this as a topic of conversation, essentially because she doesn't, I don't know whether it was a miscommunication with the doctor's review in the morning or whether the sort of plan of action wasn't clearly discussed with her, but she was quite upset at the idea of going for a cesarean the following morning when she wanted to aim for a vaginal birth. Observations, as you can see, are still sort of normal. Blood pressure is a bit lower, but I wonder if that's positional here. So essentially the day staff handed over to the night team that this woman would like to have a conversation with the obstetrician on sort of evening ward round, just so that they could have this conversation about what to do going forwards, because she was very, very, very keen to avoid having a cesarean section. The night team reviewed at 2100 because of prom, and then the plan was made to transfer this lady to labour ward for augmentation when a bed became available. So we're now the 30th. She's now 37 plus 1. At 01:48 in the morning, the obstetric registrar had a review while she was on labour ward and discussed the options. So she was offered a caesarean section. She was offered Synto. All of the risks were discussed with this client, and then she made the decision that she wanted to go ahead with Synto and do a trial of it to see if this would help her labour progress. The Toko is now picking up. We're getting some contractions here. They do an ultrasound scan at around 1:55 in the morning just to confirm position of the baby. And as you can see with those contractions, we are getting some sort of baroreceptor decelerations here. The rest of the Toko, I don't know how often this woman was contracting, just due to the fact that it's not documented. But from what I'm kind of seeing here, I'd go with the fact she's probably contracting about 2 in 10. They've zeroed the Toko about 4 times in the space of 10 minutes between 1:50 and 2 o'clock in the morning. So I'm not really sure what was going on, if she was just moving positions and getting comfortable and they felt like they needed to readjust it. But just bear in mind, the more you do that, the more we're not going to pick up that uterine activity. And they keep zeroing it after the contractions as well. So I'm not quite sure what was going on in this room, but yeah, she's moving position at around 2:20, which is where you can see that loss of contact, which is very clearly documented, which is great. And then, yeah, we just continue with the CTG. Again, baroreceptor decelerations, but our baseline is lovely and stable. This baby is telling me that they're happy at this point. Anyone want to do anything additionally? She's now prom, so we're now sort of 28 hours prom. She's over on labour ward. What's our plan? Obviously, she wants to start Synto, but anything anybody wants to do?
Maybe her blood CRP.
Yeah. Why?
Because she's prom, I can see the temperature is settled, but it would be advisable to do even her FBC and stuff in case, because we're starting oxytocin, she could be high risk for going for Caesar. So we would need some bloods.
Yeah. We're going to need to do some bloods anyway if she's going to have an epidural. I'm not sure, unfortunately, when the last ones were taken, but she would have needed to have some bloods just prior to that because they always like to check the platelets levels, don't they? CRP, I guess, could have been added to it. We don't routinely treat with antibiotics after 24 hours prom, which is quite uncommon in comparison to quite a lot of other trusts, specifically across London. I think the majority of them do actually check CRP and start IV therapy at 24 hours just due to the increased risk of infection. But at Croydon, we are much more of a let's treat when it occurs as opposed to treating prior to that. So yeah, again, no sort of harm, but if she's not showing any outward symptoms of it, there's not necessarily a real need for it. But yeah, there's, again, if we're taking bloods, then that gives us a bit more of an overall clinical picture. Cool. We continue. It all gets a bit hectic in the next 40 minutes. So the doctor and the midwife in charge come into the room at around 2:30 in the morning. There's some loss of contact again due to the change in position. Doctor leaves and then comes back at 2:40. So does the midwife in charge, and she comes back 5 minutes later. The registrar does a review at 2:40 in the morning and says that they recommend a cesarean section due to this poor trace and then the fact that we're not able to start Synto at this point. In the documentation that the registrar has written in regards to the reason for a cesarean section, it's quite clearly documented that this woman was very unkeen to have a cesarean section and was feeling as though she was forced into having a cesarean section. So this one patient agreed to have a cannula inserted, which she had previously declined when she was on Hope Ward. And Hartman's was started at 2:54 in the morning. Then at 3:05, so half an hour later from when they originally came for a review, the client declined a cesarean section as she'd like more time to make this decision for herself. Anybody got an opinion or a view on this CTG and any concerning features that we can see here?
Why was Hartman started?
That's a very good question. There's no report.
I got the answer to that question.
You've got the answer to that question.
No, I'm just joking. So what I'm seeing here is I cannot tell you what the baseline is because it looks like it went down or it could be gone to maternal or it's a bit up and down, although the variability is still good.
Mm-hmm.
And the
Okay,
TOCO is also doing something else there.
Yeah, but what are your
irritability.
What are your concerns? If you were to say we can't start Synto, what is your reason for not starting Synto? What is the concerning features on this CTG that says to you, you can't start Synto on this CTG?
There's a lot of loss of contact, and as well as the baseline is not certain.
Okay, so there's lots of loss of contact. What can we do?
FSE?
Yeah. When was the last time this woman was examined?
Has she been examined since she was found to be 2 centimeters, like 3 days ago?
No.
Okay.
So you've got a lady on labour ward who is very keen for a vaginal delivery. You've got loss of contact on the CTG, which is causing you to have concerns. She hasn't been examined in over 24 hours, but she's now prom. Now, obviously, we don't want to introduce infection, so we would aim to keep vaginal examinations to an absolute minimum, specifically when people are prom. However, we haven't examined this woman in over 24 hours, and the decision is being made essentially that due to CTG concerns, we want to take her for a caesarean section as opposed to starting Synto. Hartman's, I'm not quite sure why this was started. Hartman's doesn't fix CTGs. There's very, very, very limited evidence to suggest that it does. NICE guidelines took this out of the guideline. I think it was actually back in 2017 as a method of, as a conservative measure, essentially. Hartman's is effective if we've got women that are tachycardic and women that are dehydrated. We also haven't done a set of observations on this woman for the last hour, and the previous maternal pulse was 87. So you've got loss of contact. We've not done a set of observations in an hour. We've started Hartman's because we've just put a cannula in. And I feel like sometimes it becomes very much a protocol whenever you go to labour ward that as soon as they're sat on the bed, as soon as there's a cannula that's in situ, that we start Hartman's, sometimes for sort of no clinical indication. We've got a patient that's keen for a vaginal delivery. We've had women previously on labour ward who have had pathological or subacute or acute hypoxic CTGs that have declined intervention. In that situation, there is nothing that we can do unless women consent to our interventions. On this CTG, if we've got loss of contact and we don't want to start Synto because we have got CTG concerns, then in order to improve the quality of the CTG, we can do something about it. We can put an FSC on to improve the quality of this CTG. I don't believe that was considered in this case. We've also, yes, it's difficult at times to determine the baseline, okay? You need to have a trace of at least sort of 3 minutes to determine where the baseline is sat. Now, I would personally say for the majority of the CTG, the baseline is sat between 115, maybe 120. There is that period of time between sort of 240 and 250 in the morning, whereby it looks like it's setting a bit lower. However, we've almost got accelerations within that period of time, and actually we've got great variability here as well. So this isn't this fetus is not telling me, looking at this, that they are decompensating and struggling with the stresses of labour. We've also got accelerations after that period of time and before that period of time. If you look at any of the research as to things like a bradycardia, so if, for example, you were looking at this and you're saying, okay, I'm concerned that this baseline has dropped and this entire period of time is actually either a bradycardia or a prolonged deceleration, the majority, I think, somebody correct me if I'm wrong here, but 90% of them recover within the first 6 to 7 minutes and 95% of them recover within the first 8 to 9 minutes. and they're much more likely to recover if you've got a normal CTG beforehand. So even if you're looking at this and you're saying, okay, I think this is a deceleration, you've got a normal trace beforehand and you've got a normal trace afterwards. This baby is not hypoxic. This baby has excellent variability, does have a stable baseline. Although it might slightly be lower, this isn't a case of terminal heart failure here, which would be an indication of the baseline dropping if it was to happen in other circumstances. I'll move on to the next slide. At 3:20 in the morning, this lady consented to a cesarean section. So at 3:20, she was consented. As you can see, there is a deceleration here, which then recovered again, and the baseline went back to normal and remained stable. And the anaesthetic review happened between 3:20 and 3:30 in the morning. The indication that was made for this cesarean section was suspected chorioamnionitis with suspected fetal compromise. Does anybody agree or disagree with that?
I don't think it's either of those.
Anybody else?
Yeah, what is the indication for the chorioamnionitis? Maternal pulse, maternal temperature?
So
Fetal
if you've got chorioamnionitis, Beatrice, what do you see happen first in the overall clinical picture? What do you see happen before anything with choreo?
The maternal temperature and the fetal heart rate and maternal pulse.
So with chorioamnionitis, you always see the fetus baseline rise first. Probably not always, that's a lie, but in pretty much the majority of cases, if you've got chorioamnionitis, this is an infection between the chorion and the amnion that is going to affect the baby before it affects the mother. So with all chorio, you'll see a baseline increase in the baby. That's the baby telling you, I'm in an infectious environment, whereas maternal observations will probably be completely normal. The longer that the choreo continues and the longer that the baby sits in that infectious environment, that will then cause maternal heart rate rise and then maternal temperature as well, pyrexia. Whereas if you were to have a mother that was infectious, you're likely to see mum's pulse go up first, mum's temperature go up first, mum's respiratory rate go up first, and then afterwards you'll see the fetal baseline increase. So sepsis, you see it in mum first. Choreo, you see it in the baby first. This baby's baseline has remained 120 or between 115 and 125 for the entire duration of her admission. So since she came in with SHROM at 36+6, the baseline has always remained the same. So the likelihood of chorioamnionitis in this case is very slim. Also with choreo, you're unlikely to see fetal accelerations. Think about it, if we've got a temperature and we're lying in bed at home, we're not going to move much. Fetal accelerations are accompanied with movements. If you're ill and you're sick and you've got a temperature and you're infected with something, you're not going to move as frequently either. You probably will still see them. It's not uncommon, but that's also less likely to happen. And also with choreo, you sometimes do see a deduction in variability as well.
So also before the C-section, did we do another VE or we are still remaining with the same one VE?
We're still remaining with the same VE that was done about 30 hours ago. This woman is contracting. She's had contractions over the course of the previous evening. She was given pethidine for pain relief, and she was given dihydrocodeine and paracetamol to help relieve her pain. She's been contracting on and off pretty much throughout the day, although unfortunately I don't know how much because it's not clearly documented, nor is it documented during her labour care either when she's on labour ward. but we can see uterine activity. The likelihood of a person staying 2 centimeters dilated for over 24 hours after she's schwom and is having contractions is quite slim. Her previous labour, she didn't labour, so we treat her essentially like a primip, but we would expect a primip to have dilated at least 1, maybe 2 in a period of 24 hours after they've been examined in bin 2. But we didn't do a VE on this woman before we took her to theatre.
Again, that would have been a psychological supportive for the woman to have been given the feedback of that she's failed to progress, although there was no scent or any action. Her body did not pick up because she actually wanted the feedback. So it would have been a bit reassuring to her that her body has just been given that amount of chance, but it didn't. But now we didn't do the VE, so we cannot even psychologically support or justify one of the justifications for the C-sections.
This is her theatre CTG. Again, you've got a stable baseline at 120. There's obviously some loss of contact. At 14:13, she had adhesions. That was when knife to skin took place. 9 minutes later, we had knife to uterus. The placenta was at the delivery site, so it was anterior high. This delivery was very, very difficult, and this lady ended up having an inverted T incision, which is something we use to basically make the incision site larger so that we can deliver the baby when there's a difficulty. The midwife in charge ended up pushing this baby's head up back into the uterine cavity because the baby's head was so low. And there was a query from the midwife in charge here that she was actually fully dilated. It took 7 minutes from knife to uterus to delivery. In this case, they had to call the consultant obstetrician in over the night, and this lady lost 950 mils. So before I move on to the fetal outcome, our key learning messages here are we need to be making sure we're monitoring contractions. I'm going to get absolutely sick and tired of saying this, but I will keep talking about it until we get much better at documenting them. We need to be very, very clear with what we're measuring uterine contractions. A vaginal examination for a decision-making examination, as in moving to theatre, is something that really, really needs to be encouraged. If you're ever in a position where you disagree with the clinical decision that's being made by anybody, so this can be if I come and do a fresh eyes and you disagree with it, you go to the midwife in charge, or you go to the obstetrician or the consultant or the manager on call. If you're ever concerned about a clinical decision that's being made, please, please, please feel as if you may be able to question it. Now, I wasn't there in this CTG, and hindsight is a wonderful thing. Well, I don't know what else was going on the unit at this time. But what I do know is there was a few things here that we missed, which actually could have very much changed the clinical outcome.
Actually, Cara, I was on that night. I wasn't actually in charge. I didn't realize this lady hasn't had a V because I wasn't in charge. So I didn't actually go into in depth what was going on. I went into the room because the midwife who was looking after wanted to support to cannulate the woman and send the blood off, and I helped move her to theatre. What I didn't realize actually that a V was never done. I didn't know that at all. That wasn't I don't think it was conveyed to the midwife in charge either. And it was difficult. It was me who actually pushed, and I mean, I wasn't obviously doing a V, but I do feel a woman could have possibly been fully. And a lesson learned, even for me, although I wasn't in charge, I feel, you know, we should really examine someone before we go, regardless how, long ago the V was, even if it was an hour ago, just to justify that, we're not fully, I didn't even realize a V wasn't done in this woman.
Yeah. Well,
And
this
I
is
did help
this
push
is
that bed into Tata as well. So now you're saying this, I was thinking, I don't know, maybe because I wasn't in charge either, so I didn't question anything.
yeah. No, absolutely. And like I said, Indra, we don't know what's going on in this situation. Sometimes we have shift situations where
Mm,
the ward round doesn't even take place because you're literally jumping from one delivery to another, one room to another. There's an emergency bell going off. We never know what's going on in these situations. But this is when the importance of a handover and an SBAR and whatnot is so important. We had something flagged up with the paediatricians the other day, which I think we all learnt from. When we call for an obstetric emergency, the neonatal bleep goes off. So they get told that there's an obstetric emergency, but for all they know, that could be a postpartum hemorrhage because that's never actually said over the sort of tannoy, if you like, that comes through the bleep system. So if you put out an obstetric emergency, the neonates are very unlikely to run to the delivery because it might be something that's happened afterwards. So the importance again of putting out a 2222 for neonatal emergency was highlighted in perinatal meetings that we have on a Friday at 2 p.m. And that's a learning point as well, because there's actually situations where the resuscitation from the paediatricians has been delayed and started by midwives. I mean, we're all trained to do it. We all know exactly what we're doing when it comes to neonatal resuscitation. But if it becomes a situation that we're uncomfortable or we have a junior member of staff that needs additional support and whatnot, and there's people that are available to help, they need to know. And I think when we're walking into theatre, when that emergency bell's going off, or even when we're going for a category 2, it's so important to just take 10 seconds to look at the overall clinical picture in a case like this.
mm.
You know? Um,
Sarah,
yeah.
hi. I just wanted to also add that I think this case might possibly highlight maybe how bias can come into play as well. I think it's a possibility. I mean, I don't, like you've already indicated, we were not there, so we don't know everything else that was going on. But to me, I think there's a possibility that that could have influenced decision making as well. Sometimes we can have a lady that we hand over to each other that she's keen to have a cesarean section, but she's not, I mean, she's keen to have a vaginal delivery, but she's not, it's not going to happen, or we don't think that she'll be able to. And because we've already at the back of our minds reached that conclusion, we manage her towards the outcome that we are looking for, whether we consciously or unconsciously acknowledge that it may, and that may account for why she wasn't examined in terms of like your vaginal examinations, because it's possible that we've already concluded that she's not going to be able to have that vaginal delivery. So we are just babysitting until we get her to a point where we're saying it's failed, let's have that cesarean section. So I guess maybe for me, like taking some learning from it is, sometimes we need to ask ourselves whether bias is coming into play. Do we need to think about setting that aside and doing a full risk assessment, doing, that complete assessment for us to be able to make a decision that's actually based on that clinical picture that we have, as opposed to what may be going on in the background or going on at the back of our minds, because that's what we've been discussing, like outside of the woman's issue. So I just thought, that's what I thought. I know that there would have been a lot of other things going on, but I think maybe bias may have played a role as well.
I totally agree with you, Evia, and thank you so much for contributing that, because that's something that we haven't discussed on here in quite a long time. So yeah, 100% that's going to be a factor in our decision making for sure. We always do have this anticipation, I think, with VBAC women okay, yeah, we probably might end up in a theatre, but actually the success rate for VBACs is 70%. And that's figures that we don't necessarily know that much and we don't think about. So yeah, absolutely. That I thank you so much for contributing that, because it's so that's another thing that's so important to consider. Yeah, fantastic. Would anybody like to guess the clinical outcome in this case? Okay, I'll take that as a no.
I was going to say maybe acute hypoxia from the challenging delivery, like just because of the, what happened right at the end. I don't know.
Yeah. Yeah, no, absolutely. And if you think about it this way, so we all know what normal pH range is. We like it to be above sort of 7.2, kind of around that ballpark. You think you've had from knife to skin to delivery, you've got 7 minutes. Now, if you're in an acute hypoxia, you drop 0.1 every so 0.01 every minute if you're in acute hypoxia. So if you think about it that way, we could go from having a baby that's a normal pH to having a baby that's actually got a very poor pH, which is very very common with acute hypoxia. But what will normally happen with an acute hypoxia is your venous pH will be completely normal, but your arterial pH will be low, because the blood flow is still going to the baby, but the baby can't process it and get rid of that, get rid of the additional chemicals that it's supposed to get rid of, essentially, which is why the pH drops. So this baby was born with APGARs of 1, 7, and 8, was born weighing 2,637 grams on the 31st centile. These pHs are the same. There has to be a difference of 0.03 for them to be considered two separate vessels. So 7.24, we'd want the venous to be at least 7.27 for them to be considered normal. So they are too close together to be considered different. I would say, based off of the fact that you are much more likely to be able to get a venous sample, that these pHs were actually taken from the venous, and that if we would have had a true arterial, it would have been a lot lower, considering the outcome. This baby was born in quite poor condition, as you can see, and required inflation and ventilation breaths. And he was started on CPAP due to grunting and admitted to the neonatal unit within the first hour. This baby's gas was repeated in the neonatal unit, and the venous pH was 7.05. So actually, this baby had a bit of compensation after delivery, essentially, and did sort of, that lactate is high. We like it to be less than 4 in babies, or less than 6, like predominantly. Our base success, we like that to be less than 6 as well, so that's also high. This baby's buffering those internal struggles that it's having, and yeah, this baby was quite poorly. Baby was returned to mum within the first sort of 24 to 48 hours, which is great, and they're now at home safe and sound. But there's definitely a lot of learning that we can take out of this case today. So yeah, does anybody have any
definitely.
comments?
I mean, me personally, I feel pushing that head off, which was very, very scary as well. It was actually scary being in that theater,
Yeah.
not, the Reg not being able to deliver that baby and trying. And when I saw put my hand, I mean, definitely, I thought, oh my God. And afterwards, I mean, of course, you couldn't say it there and then, did you do a V before we move on? I knew a V wasn't done then, but I didn't realize as long as that was like, it's awful that we've missed it that much.
Yeah, absolutely. But also, this is another thing that I don't think we do very frequently, is if you go into theatre, I hope everybody is aware of this, but we can come out of theatre. So if, for example, we were concerned with the CTG, we've gone into theatre, the CTG's gone back on, and as we can see, the baseline's still stable. We've got good variability. Yes, there's a bit of loss of contact, but it normalizes beautifully afterwards. you've got a normal CTG here. If we would have done an examination in theatre and found her to be fully, she could have gone back to the room and had a delivery. Or if there were still concerns that were raised by the team, she could have had an instrumental and had a vaginal delivery whilst in theatre. So let's get it out of our heads that we have to go into theatre and deliver a baby immediately, because actually we don't. And this is when Mr. Naguib would pop in and say, obstetrics is an art form. And what we do in our clinical practice is something we can always learn from and something that we can always change, essentially. And this is one of those things that I think we need to change the dynamic with.
Also, Carol, the theme which we always talking about every Tuesday about monitoring the contractions, the midwife who was with the woman is the one who would really have been advocating that although we have not given her Sinto, these contractions are behaving like this, they are coming 3 or 4, they are strong, let's do a VE.
I think everywhere from going, Beatrice, from going into the room to take the blood to send it off for her.
Yeah.
This woman, I think she's got a bit of a needle phobia, and there was a lot of crying. So whether the midwife,
Yeah.
I don't know, was concentrating on doing that cannula and talking to her about getting a cannula, because a decision was being made. I don't know, because I wasn't there to be honest all the time. To either start Sinto or, you know, feeling that because she's had the D cells on the ward, it's an abnormal trace. I don't know why the decision was made to go for theta. But the woman I knew was crying quite a lot. So I don't know if that's what confuses the midwife. And why she never kind of stood up for the lady either. And, you know, never, you know, verbalized her view was never done. I don't know how that got missed.
But also, if you're, I don't know, I can't remember, but if you're a midwife that's not necessarily confident in speaking up or being able to challenge decisions, then you're less likely to do it, which is just why I think we also need to empower anybody in the unit. This isn't a message to junior staff or new staff or anything like that, but empower people to be able to question decision making. If you've not got concerns and somebody else has, then using the teach or treat approach when it comes to, you know, how we can all learn together. And I think, you know, like I said, there's a lot of learning from this case. But I just hope that those key messages are put out there and encouraged.
Or even just say, oh, do you think we should, you know, should have eat to see what you're doing?
Yeah.
Kind of thing. So it's not even challenging someone, kind of prompting them.
Yeah, and
Absolutely.
also maybe reintroducing that buddy system.
What do you mean?
Your buddy system.
Oh, okay.
We don't use a buddy system, Beatrice.
Yeah, that's what I'm saying. Maybe reintroducing the buddy system. Because I remember in my former trust, we used to have like the way you do fresh eyes coming into your room. It helps as well.
Yeah, absolutely. I mean, those fresh eyes assessments are definitely going to help. But if you've got two people that don't want to question a decision, then it's not necessarily made a difference. It absolutely could have done. You're absolutely right. But we never know if that would have made a difference.
And again, because she was not in a established labor, so there was no fresh eye necessary coming. Yeah. But if you have got your buddy, you're like, what is happening? What is happening? You have that one-to-one discussion, and maybe you pick it up with your buddy.
I mean, I think the buddy system is a great idea. I definitely think it works in some trusts. We've trialed it here before and it didn't really work very effectively. But just the power of fresh eyes is something that we use that maybe could have helped. But fresh eyes, I believe, was actually taken. And also there was 2 additional midwives in this room before she was transferred to theatre. So, even though they had 2 fresh people in there, that still didn't
Mm.
make a difference.
Mm.
Perfect. Does anybody have any other questions? Perfect. Thank you everybody for your contributions this evening. Yeah, I hope we've all taken some key messages away from this one, and I'll see you all next week.
Thank you.
Thank you.
Thank you.
Thank you.
Thank
Bye.
you.
Thank you.
Bye.